So with that, we'll start with our first session here where we're going to be covering upper GI disorders. I'm pleased to introduce our first speaker, Dr. Mark Ovsiowitz. So he received his medical training at Drexel University College of Medicine. We recruited him here to UCLA in 2007. He currently practices out of our Santa Monica UCLA group, where he's also the fellowship site director, and he'll be talking on dysphagia this morning. Mark?
Good morning, everyone. Welcome. Thank you for spending your Saturday morning and day with us. The first session we're going to be talking about today is dysphagia. So I'm just going to start with a brief general overview of what dysphagia is, and then we'll move into some of the more specific underlying etiologies and diagnosis. So in its most general sense, dysphagia simply refers to difficulty with swallowing. And this can either be with liquids, with solids, or with both. And we'll talk about later the importance of sort of elucidating a clear history as to which one of these things may be causing the underlying etiology. Dysphagia can then be further subcategorized into both oropharyngeal and esophageal dysphagia. Oropharyngeal dysphagia simply refers to a disorder of transfer of food or liquid from the oropharyngeal cavity into the esophagus, which should be distinguished from esophageal dysphagia, which is a more inherent or intrinsic problem with the esophagus itself or the lower esophageal sphincter. So I just want to point out another couple of terms which sometimes can be confused with dysphagia, but which really shouldn't be. So odynophagia specifically refers to painful swallowing, which is different from the difficulty swallowing associated with dysphagia. Now they can occur together, but just because somebody has one does not necessarily mean that they have the other. The other term which I put up there is globus, which sometimes can be difficult to distinguish if you don't take a clear history. And the reason is globus sensation, patients will often describe an abnormal lump or something in the back of their throat, which is the same thing that they can describe when describing dysphagia. The difference is globus occurs in the absence of any food or liquid. So it's between meals versus dysphagia is actually when they're eating the meal, they have the same symptoms. The location of the symptoms varies between oropharyngeal dysphagia and esophageal dysphagia as well. And so again, simple history taking can most of the time elucidate the difference between these things. And so with oropharyngeal dysphagia, the symptoms are generally high up in the cervical region. Patients often describe choking or coughing or drooling immediately when they ingest the food. Whereas with esophageal dysphagia, usually the symptoms don't occur immediately. Usually it's a couple of seconds afterwards because the food actually has to enter the esophagus in order to cause symptoms. And so we can, based on time course, is one way to sort of distinguish these things. We often ask patients when they have dysphagia to point to where the food feels like it's getting stuck. Sometimes this is helpful and other times it's not. So if they point to a retrosternal area, this oftentimes correlates with the exact or more or less location of where the lesion may be in the esophagus. Whereas if they point to a suprasternal location up in the high esophagus, it doesn't necessarily mean that's where the etiology of the symptoms is coming from. It can be referred symptoms all the way down as low as the lower esophageal sphincter. So that's just one thing to keep in mind when taking a history. For the purposes of this talk, we're going to dismiss oropharyngeal dysphagia for now. We're going to just focus on esophageal dysphagia. And so when we talk about esophageal dysphagia, we then further categorize it to help define what the underlying etiology is. And we categorize it into structural or anatomical etiologies versus underlying motility etiologies. And just as in anything else, the history is of paramount importance. And so we talk about whether or not symptoms are related to liquids or solids or both. And it gives us sort of a general idea. It's not 100%, but it gives us sort of a general idea of what category this may fit into. So symptoms that are occurring with liquids and solids tend to imply that there may be more of an underlying motility disorder, whereas symptoms that are solids or initially start with solids and then progress to liquids implies that there may be more of a structural anatomical etiology underlying the symptoms. We then want to ask about whether or not the symptoms are intermittent or constant. Do patients get it every single time they eat, or is it once a week, once a month, once a year? Similarly, we want to talk about whether or not the symptoms have progressed. Are they getting worse over the past 3 months or 3 years, or has this been the way that it's been for the last 10 years of their life? It's also very important to talk about underlying conditions. So is there any history of connective tissue disease? Is there associated heartburn? Do patients have weight loss? Do they have any nausea? Do they have vomiting? Do they have hematemesis? All of these things give us clues and ideas as to what may be causing the underlying etiology of these symptoms. And then medication history as well is important as well, because medications themselves can sometimes be associated with irritation and then subsequent dysphagia, but medication history can sometimes give us a clue as to what other underlying medical conditions patients may have forgotten to tell us about. So when we talk about diagnosis, the history we said is important, but there are some other diagnostic modalities which are available to us, which we'll just briefly touch on. So barium esophagram is a very good and it's a perfectly reasonable, non-invasive way to image the esophagus. The main limitation of barium esophagram is, number one, it doesn't allow us to get direct visualization of the mucosal detail of the esophagus. The other main limitations are that it does not allow for any tissue sampling, and most importantly, it doesn't allow for any therapeutic interventions if they need to take place. Having said all of that, it may actually be superior in some situations to endoscopy, especially when looking at the very proximal esophagus, right around the upper esophageal sphincter, because this area can be sometimes difficult to image or see on standard endoscopy. The next thing that we'll talk about is endoscopy, which we're all familiar with. Endoscopy is probably the most sensitive way that we have of looking at the esophagus, the anatomy, the mucosal detail, and therefore evaluating for structural lesions. And it gives us the huge advantage of being able to sample the tissue and to do any therapeutic interventions that may be needed directly at the time of exam. Esophageal manometry is sort of the gold standard when it comes to diagnosing underlying motility disorders, and we'll talk about that briefly in a little while. So these are some of the common diagnoses, and by no means is this list extensive or comprehensive, but just some of the things that I wanted to sort of bring to your attention and use it as examples to talk about. So the structural anatomical things that we'll touch on today are eosinophilic esophagitis, peptic strictures, Schotzky's rings, and then malignancy. And when we'll talk about the underlying motility disorders, we'll touch on achalasia, diffuse esophageal spasm, and then systemic sclerosis. So first, we'll talk about eosinophilic esophagitis. Typical symptoms with eosinophilic esophagitis are intermittent dysphagia to solids. And so sometimes these symptoms may have been going on for a year, a couple of months, but it's not uncommon that you'll see people who say for the past 20 years, every once in a while they feel like chicken or steak or bread gets stuck in their esophagus. And they may think nothing of it. They may go to a restaurant and say it's just that they ate too quickly or they ate too fast. But if you ask a little bit more and you take more history, they'll say, you know what, it's happened more often, or it's happened more than I think it should have. And they may have actually been in the emergency room a couple of times requiring an endoscopy because of food impactions. This occurs as a direct result of infiltration of eosinophils into the esophagus, and we'll talk about why that's important in the diagnosis. There's a clear association between allergies and asthma. So this goes back to the initial history and the importance of taking a history and figuring out are there any other underlying comorbidities or medical conditions. The diagnosis does require endoscopy because we do need mucosal samples and we do need histologic evaluation in order to make the diagnosis, although we can get clues with other modalities. On endoscopy, the appearance is quite variable when it comes to eosinophilic esophagitis. The endoscopy can be completely normal and look like nothing is going on, but it doesn't preclude the diagnosis. So anybody who has typical symptoms, intermittent solid food dysphagia, even with a normal, completely normal endoscopy, biopsies are obtained specifically to rule out this condition. The more classic textbook findings are multiple esophageal rings, and I'll show you a picture of that in a minute, as well as small esophageal plaques, linear furrows of the esophagus, and sometimes you can even see strictures in the esophagus. As I mentioned before, the hallmark or the cornerstone of diagnosis hinges upon biopsy. And in order to make the diagnosis, you need to see 15 or greater eosinophils per high-powered field. Now, the one caveat is that there may be some overlap between the histologic findings of eosinophilic esophagitis and GERD. In that GERD, you can see increased numbers of eosinophils as well as in eosinophilic esophagitis. The main difference is with GERD, the predominant numbers of eosinophils tend to be in the distal esophagus, whereas with eosinophilic esophagitis, it can be spread throughout the entire esophagus. So we do biopsies in multiple different areas and put them in different containers so that if we see there's a mild predominance in the distal esophagus, but there's no increased eosinophils in the proximal or mid-esophagus, it more likely points to diagnosis of GERD, whereas if it's spread throughout, we think more of EOE. So once we've made the diagnosis, then we have to talk about therapy. And so the good news is that there's good medical therapy for eosinophilic esophagitis. The hallmark and the cornerstone of therapy is topical steroids. And so systemic steroids really have no role in this disease, but the topical steroids are very, very effective. So we usually start with swallowed fluticasone. It's the same fluticasone that we use for asthma, but we essentially tell patients to ignore the instructions on the box that tell them to inhale the medication. And instead of inhaling it, they take 2 puffs twice a day as the normal standard dose, and they swallow the medication. They're then instructed not to eat or drink for at least 30 to 60 minutes after that in order to maximize the amount of time that the medication stays in contact with the mucosa. And then we usually tell them to rinse their mouth out and spit out with water to try to reduce the risk of the development of oral thrush. And this therapy is effective in the vast majority of patients, and usually their symptomatic control is quite quick, sometimes within a couple of days, and certainly within a week or two, most patients start to feel better. There are some other therapies which have been looked at. So the leukotriene inhibitor, montelukast, has been looked at, and initially the studies show that this may be of some benefit in the treatment of eosinophilic esophagitis, but some of the more recent studies haven't necessarily confirmed this. And the more recent studies actually also show that the doses that this medication has to be used on are so high that it probably precludes the normal use of this medication. Elimination diets are oftentimes used as well, especially in the pediatric population, and they can be effective. The one limitation with the elimination diets is that they're very difficult to adhere to for most people who enjoy eating an average diet. And then esophageal dilation is sort of reserved for a select group of patients. In patients who don't respond to medical therapy or who have severe or persistent strictures, esophageal dilation can be performed, but it needs to be performed with caution and with care because there is an increased risk of perforation. So initially, the standard teaching was try to avoid dilation at all costs in these patients because the risk of perforation is so high. And it used to be thought that it's as high as 5 to 7% in these patients. But more recently, people have looked more closely, and it's probably not that high. It is higher than in the normal population, and so it can be done, but it needs to be done with care. And this is a typical picture of eosinophilic esophagitis, and you can see sort of these concentric rings in the esophagus and then these linear furrows, which are typically what we see. Now we're going to move on to talk about peptic strictures briefly. And peptic strictures recur as a result of exposure of the esophageal mucosa to acid, and it's a direct result of injury to the mucosa. They're associated with GERD, and so a long-standing history of heartburn is clearly a risk factor for the development of peptic strictures. Having said that, most patients with GERD do not develop peptic strictures. Because GERD is so common, the vast majority of patients will have no complications from the GERD. And up to 25% of patients with peptic strictures, if you talk to them and ask them about their history, they've never actually had any history of heartburn symptoms that they can elucidate. Symptoms are typically progressive, and they usually start with solids. In rare situations, if patients go long periods of time without any treatment and the luminal diameter becomes so severely narrowed, the symptoms can progress to dysphagia with liquids. And the time course of this progression is quite variable. The risk factors, as we talked about, are GERD. So males have a higher incidence. Older age and longer duration of symptoms are also risk factors. And then really any other condition in which there's an increased amount of acid exposure in the esophagus can increase the risk of development of peptic strictures. So Zollinger-Ellison syndrome, scleroderma, or even in patients who have a history of achalasia who've undergone prior myotomy without a wrap and have increased acid exposure can in some situations develop strictures. The diagnosis of peptic strictures really is seen in one of two imaging modalities. So barium esophagram, again, is a reasonable study and have a pretty typical appearance on barium esophagram, and I'll show you what that looks like in a second. But really, barium esophagram, again, is limited by the inability of us to do any therapeutic modalities or interventions at that time. So in anyone who were suspecting this, normally we would do an endoscopy so that we can actually do therapy at the same time as diagnosis. Because the cornerstone of treatment is dilation, and then after we dilate, we want to reduce the risk of recurrence, and so we want to reduce the underlying causes, and so long-term PPI therapy is oftentimes instituted in these patients. And these are typical appearance of a peptic stricture on a barium swallow, and you can see the smooth tapered narrowing here. And then this is an endoscopic appearance of what a peptic stricture may look like in the area that we would dilate on endoscopy. Next, we'll talk briefly about Schotzky's rings. Schotzky's rings are benign mucosal rings that occur in the location of the gastroesophageal junction. There may be an association with gastroesophageal reflux disease, and there is an association with hiatal hernias. So it doesn't mean that if somebody has a hiatal hernia, they're going to have a Schotzky's ring, but if they have a Schotzky's ring, they probably have a hiatal hernia. They, again, cause intermittent dysphagia to solids and not to liquids. So the symptoms sometimes can be indistinguishable from eosinophilic esophagitis, but the endoscopic appearance and the barium swallow appearance are completely different from eosinophilic esophagitis. And I'll show you what those pictures look like. The treatment is relatively simple for Schotzky's rings. They're quite amenable to dilation, and the way that they're dilated usually is with either a balloon through the scope or we can use a savory dilator in some situations. And this is what a Schotzky's ring looks like on barium esophagram, and you can see the mucosal ring here, and then this is a very typical appearance of a Schotzky's ring occurring right at the junction, the squamocolumnar junction, and you can see it's a benign mucosal ring, and when we dilate it, we basically tear this mucosa here. Esophageal cancer is the last anatomical etiology that we'll talk about, and the result of, or the cause of dysphagia in esophageal cancer is directly related to the narrowed luminal diameter as a direct result of the malignancy there. And so the symptoms start with solids usually, and as the cancer progresses, then can progress to liquids as well. Typically, there's other constitutional symptoms. Usually occurs in older patients, oftentimes with weight loss, sometimes with hematemesis, early satiety, all of those other things that we would elucidate on a normal history. Barium esophagram, again, can diagnose this, but again, is severely limited by the fact that we can't do any mucosal biopsies. And obviously, to make the diagnosis of cancer, we're going to want direct mucosal examination. So shifting gear from the structural anatomical etiologies, we're going to talk now a little bit about the underlying motility etiologies that can cause dysphagia. And again, this list is not comprehensive, but it's some of the more common things that we'll talk about. So achalasia occurs usually sort of an insidious onset, gradual progression. It's not something that somebody wakes up with one day and then a month later has severe symptoms. Male-female frequency is equal in this disease. And the symptoms generally occur in response to solids and liquids, which distinguishes this from the underlying anatomical etiologies. Patients also not infrequently complain of regurgitation, and the regurgitation can sometimes occur immediately, right after they eat. They say a few seconds after they eat, they bring that food back up. But other times patients will tell you that hours to even a day after they eat something, they bring up that undigested food, and that should be a clue to this disease. Chest pain can also occur with achalasia. Typically, chest pain occurs in younger patients with achalasia versus older patients. And the way that achalasia sort of has a characteristic appearance on all three of these imaging modalities. So with barium esophagram, typically the proximal esophagus is very dilated and the barium is slow to drain. So we can oftentimes see a fluid line or a barium line in the esophagus, and then there's a smooth tapered narrowing at the GE junction, which, as we all know, is referred to as the typical bird's beak appearance. We shouldn't see any mucosal abnormalities or any masses or anything like that on barium esophagram. If we do, we need to think of other underlying etiologies. Endoscopy can sometimes be completely normal in achalasia, but other times, again, we see a dilated proximal esophagus. Sometimes there's retained food or liquid despite the fact that the patient hasn't eaten or drank anything for at least 6 hours. And then as far as the gastroesophageal junction goes in achalasia, sometimes when we pass the scope, there's minimal resistance, but there shouldn't be any great difficulty in passing the scope at the gastroesophageal junction. Although the pressure is higher there, it still should be able to pass fairly easily in achalasia. If it doesn't, we should think of other things, which I'll talk about in a minute. But then if we really think that there's an underlying motility disorder, despite what we see on the direct imaging modalities, esophageal manometry is what's required to make the diagnosis. And so on esophageal manometry with achalasia, we see aperistalsis. And this can either mean complete lack of any contractions in the esophagus at all, or you may actually see contractions which are simultaneous but aperistaltic. There's also incomplete or impaired relaxation of the lower esophageal sphincter, and oftentimes elevated resting lower esophageal sphincter pressure, which isn't required for the diagnosis, but is oftentimes present. There's 3 different manometric findings that we can see with achalasia. The classic appearance is type 1, in which we see essentially no change in the esophageal pressurization. There's no contractions, and there's just complete aperistalsis without any pressurization changes. Type 2, we see simultaneous pressurization, which spans the length of the esophagus. And then type 3 is the very strong simultaneous lumen-obliterating contractions or spasms, which we can see with achalasia. Now, I mentioned before that if we see any abnormalities on the barium esophagram, mucosal abnormalities, or if there's any difficulty passing the endoscope at the gastroesophageal junction, we should think of other things like pseudoachalasia. Pseudoachalasia can have the exact same symptoms as typical idiopathic achalasia. Patients complain of the same thing. They can actually have a manometry done, and the manometry findings look exactly like achalasia. And so we have to have a high index of suspicion because the underlying cause of pseudoachalasia can be due to adenocarcinoma of the cardia, or is sometimes associated with perineoplastic syndromes. And so there are some risk factors or some red flag warning signs that should go off that if anybody has had a short duration of symptoms, if they tell you it's only been going on for 6 months or less, if they're over the age of 60 years when they have the onset of the symptoms, if they have any other associated or constitutional symptoms such as weight loss, or again, difficulty passing the endoscope, we need to do a full evaluation for pseudoachalasia first. That includes endoscopy, but if the endoscopy is completely normal, it doesn't necessarily exclude the diagnosis because some of the lesions in the cardia may be deep infiltrating lesions that cannot be seen on endoscopy and can have negative mucosal biopsy. So if we really have a high index of suspicion, we can go on to things like CT scan or endoscopic ultrasound to get a better look at the deeper layers to make sure that there's no deep infiltrating tumor there. A little bit about diffuse esophageal spasm. So diffuse esophageal spasm does not always cause dysphagia, but if it does, it's usually intermittent dysphagia to both solids and liquids, much as the other underlying motility disorders do. It's also possible to have chest pain with diffuse esophageal spasm, even in the absence of having dysphagia. And the results of the barium swallow are quite variable, so are not very helpful in making the diagnosis of DES, but can be helpful in excluding other underlying structural and anatomical problems. Manometry is required to make this diagnosis, and typical manometric findings are that we see simultaneous contractions in at least 20% of the wet swallows. Systemic sclerosis is another condition which can cause dysphagia by one of a couple of reasons, and we'll talk about that. A lot of patients with systemic sclerosis have typical heartburn symptoms. And because the dysphagia can be caused by one of two mechanisms, sometimes the dysphagia initially occurs as both symptoms to both solids and liquids, and other times it starts with solids and then it progresses to liquids over time. And the reason is if the dysphagia is as a result of the underlying connective tissue disease, the symptoms generally are generally felt in response to solids and liquids. But because one of the hallmarks of systemic sclerosis, esophageal involvement, is that the lower esophageal sphincter is hypotonic and the pressures are low, a lot of patients with systemic sclerosis have free acid reflux, and because of this, they're at risk for developing esophagitis and therefore peptic strictures. And so patients with peptic strictures with scleroderma present much the same way as patients without scleroderma and peptic strictures do. Progressive dysphagia, solids, and then liquids. And peptic strictures can actually occur in up to 50% of these patients. 90% of patients with systemic sclerosis will have some sort of esophageal involvement, although only about 40 to 50% of these, or up to 40 to 50% of these patients may actually have no symptoms at all. The part of the esophagus that's involved is the distal 2/3 because that's the smooth muscle of the esophagus, whereas the proximal 1/3 or skeletal muscle part of the esophagus is usually spared in this condition. On manometry, again, we see aperistalsis much the same way that we do with achalasia, but the amplitude of the contractions are low. We don't see the high amplitude contractions that we can see in type 3 achalasia. And then the lower esophageal sphincter pressure is lower absent when we talk about systemic sclerosis. And this is just sort of a general guideline. It's by no means meant to be used as the way to diagnose everybody, but it's just sort of a general idea. So you can see that if somebody's got dysphagia, we want to categorize is it solids or is it liquids or both. And then intermittent solid food dysphagia may mean that there's an esophageal ring like a Schotzky's ring or eosinophilic esophagitis. Progressive dysphagia to solid foods with heartburn or in the setting of heartburn symptoms may mean that there's a peptic stricture with other constitutional symptoms, weight loss, etc. We should think about malignancy. And then esophageal dysphagia, including liquids, we should think about motility disorders, especially in the setting of a negative endoscopy or barium swallow. And our next step in those situations should then be esophageal manometry.